It's a pleasure to be here. So I will be talking about immune phenotype switching. I slightly changed the title of the topic. So I would like to start with a very simplified scheme here to show you again what are the key immune pathways which are important for us dermatologists. So I divided them in 5. As I said, it's oversimplification. But there is a number of pathways which are linked to adaptive immunity. So linked to T-cell differentiation, we have T-cells that can become Th1 cells producing interferon gamma, naive T-cells that can become Th2 cells producing IL-4, 5, 13, 31, as we heard. And then there are the Th17 cells which produce IL-17 and 22. On the other hand, we have pathways linked to innate immunity, such as dendritic cells producing type 1 interferons and dendritic cells or other cells producing IL-1 family member cytokines such as IL-1 beta and IL-36. So why are these pathways so important? Because they are directly linked to the pathogenesis of skin diseases, which we know. We know psoriasis, Th17 disease, atopic eczema, Th2 disease. We have other diseases which are linked to Th1, such as lichen planus. And then we have 2 diseases linked more to these innate pathways, such as lupus erythematosus, which is linked to activation of plasmacytoid dendritic cells to produce type 1 interferons, and neutrophilic disease, which are linked to the overexpression of IL-1 cytokines. We have very good targeted therapies which can block these pathways. They are very efficient, but we have always non-responders, raising questions whether we are targeting the right pathway, whether we have the right diagnosis, whether even we have some immune switches. And we performed a study to try to define these pathways molecularly in order to be able to adapt them onto the individual level and so search on each patient whether these pathways are actually activated. And to do that, we cross-compared the diseases that I've just shown you. We performed transcriptomics, differential expression analysis of one disease versus all the others in order really to be able to identify this key core immune pathway which is underlying the pathogenesis of this disease. And we performed nanostring analysis, and to make a long story short, here we identified the genes. We plotted them on this heat map on the y-axis here, and you see, to make a long story short, as I said, is that all the diseases, for example here psoriasis samples, they all cluster on an unsupervised way together based on the common expression of these genes which we identify here overexpressed in red on this heat map. They are all linked to Th17, so we call this the Th17 model. Atopic dermatitis samples, they're all clustered together based on Th2 model, lupus based on type 1 interferon model, lichen planus based on Th1. Here we have some Wells disease, so eosinophilic cellulitis, which have an eosinophilic signature, and then neutrophilic disease, which have this myeloid signature, which we could divide into neutrophilic and macrophagic signature. So this is the basis of what I want to present today. So we have now a molecular cartography which allows us, on one hand, to diagnose disease. This is highly efficient. We can these sentinel diseases which I just shown you, we can diagnose them, but we can also diagnose less clear diseases, and I just would like to show you just a couple of examples. So we have an erythroderma case that was hospitalized 3 times. We thought it was a drug eruption, but when we performed nanostring clustered with AD, so it was an AD erythroderma. It had a dominant Th2 profile, as you can see here. So we took it, we clustered it in this cartography, clusters with the Th2, dominant Th2 profile, and it responded to IL-4 receptor, anti-IL-4 receptor therapy, so dupilumab. Another case, unclear case, very eczemative form in rash in a psoriasis patient is the psoriasis AD. Again, we performed nanostring. It clusters in the middle of the psoriasis with the dominant Th17 profile, and it responded to IL-17. On the other hand, this one, is it psoriasis? Is it nummular eczema? I'm sure you in your clinic, you have these these patients where it's not always very, very easy. So we performed nanoscreening. This clearly clusters in the middle of atopic dermatitis samples, has a dominant Th2. We gave dupilumab, and it responded to therapy. So this cartography is highly efficient of helping us to diagnose these unclear cases. And also another thing we can do is to try to match the dominant model in this cartography with our treatment. So here I show you, for example, this is in atopic dermatitis. You see the dominant expression of the Th2 model compared to all the other models. So this would be matched to an anti-IL-4 receptor, so dupilumab therapy, but not to an anti-IL-23 or anti-IL-17A therapy. On the other hand, this is clearly a Th17 dominated disease. It's a psoriasis. This will be matched if you use an anti-IL-23 and 17 therapy, but mismatched if you use dupilumab. This is just to show you what I mean for matched and mismatched. And we did a study now with 80 and plus. We are now 100 plus patients. All the responders displayed a matched model, so we had no clinical responder which had a mismatched model. However, if you look at the non-responding patients, we have 40% in the pretreatment biopsies which had a mismatched model. What was very interesting is that if we rebiopsied the non-responders, we found over 84% of the biopsies showed a mismatched profile, which is somewhat discrepant to what I've just shown you before. So here, this suggests us that there might be a switch of immune phenotype during the treatment, and this is the topic of my talk, and I would like to show you a few of these immune switches. So here I start with a 77-year-old male patient which has an adult onset atopic dermatitis, and he was given dupilumab therapy, but he flared after 3 injections, very eczematous, also on the scalp, on the back. So what is going on here? So in this patient, we had a pre-treatment biopsy, and we rebiopsied this flare. What did we observe? So the pre-treatment biopsy, it clusters in the middle of the Th2. It was an atopic dermatitis. It was the right diagnosis to put him on dupilumab. However, what did we see afterwards? So after the 3 injections of dupi, the flare of the eczema, we saw the decrease of the Th2 profile, but the emergence of a Th1 profile. And this is shown here also in quantification. So we see pre-treatment, the highest, the dominant pathway was Th2, and it switched to a dominant Th1 and a decrease of the Th2. We had several patients now with that. Here I show you 5 patients which flared up during Dupixent therapy. They all had a dominant Th2 here in blue before therapy. This is the pre-treatment biopsy. However, what happens after the post-treatment biopsy, when we had the flare, we had the emergence of this Th1 dominant pathway. So this is a switch from a Th2 to a Th1 dominant pathway. We know that IL-4/13 controls the IL-12 production. If you block it, we can imagine we have more IL-12, and this drives a Th1 response. What do we do? Therapeutic rematching, Th1 dominated. So we use the JAK inhibitor, which we know, JAK1/2 inhibitor, which we know can target interferon gamma signaling. And we had, after 4 weeks of parasitemia, a complete clearance of the rash. So another switch is this, what Johanna has already talked about, is this paradoxical reaction here. What we have is the dupilumab, so anti-IL-4 receptor-induced paradoxic reaction. So we have these psoriasiform skin lesions. In the literature, they occur between 2 to 6% of patients. So I'm sure you all also have seen that. So it's not so infrequent. Despite initial response to the therapy, here you see one of the clinical, one of my patients with the appearance of these quite well demarked plaques, scaly plaques. And so we performed, again, nanostring profiling. We see that untreated before therapy, this was a clear atopic dermatitis falling into the Th2 pathway. What happened in this lesion here, we have a clear Th17 pathway appearing here after Dubixent. Apologize, it's the wrong way. So here again, the numbers, clear dominant Th2 pathway here, and after 4 months, starting Dupi, he developed these psoriasiform lesions, which were Th17 dominated. On the other hand, we have the reverse phenomenon. We have also psoriasis patients which are treated with anti-IL-17 therapy, and they can develop eczematous paradoxic lesions, so what we call paradoxic eczema. They occur in the literature is 5.8%, so also not unfrequent. They occur with all types of IL-7, Th17 blockade, so IL-17 blockade, but also Th17 blockade. They have been reported with anti-IL-23. Here, one patient, so untreated, clear psoriasis, Th17 dominated here. After secukinumab, switched to Th2 profile. Here are the numbers. Sorry, this is not the correct. So it was a Th17 to a Th2 profile. So what happens here? So we think we have a balance between the Th2, Th17 profiles. We know that Th17 through IL-17 controls somehow TSLP induction. If we block IL-17s, we have increased TSLP, which may drive then the Th2 profile. On the other hand, if we block IL-4, IL-13 signaling, we may have, again, more IL-23, which drives the Th17 thing. So we have a yin-yang between the Th2 and the Th17 pathway. Another paradoxical reaction, which is known and described since many years, is the anti-TNF induced paradoxical psoriasis. This occurs in 5% of the patients treated with anti-TNFs. It's a class effect. Often it manifests. It can be pustular, palmoplantar. It can be on the entire integument. It can be often on the scalp. So we did profiling. These paradoxical reactions, they fall actually into psoriasis. They have Th17. But when we looked a little more closer and we looked at type 1 interferon expression themselves, we have a highly dominant type 1 interferon expression. We have described that years ago in 2015 with Kurt and Conrad. This is really dominated by type 1 interferon. How does this occur? We have described that. We know that interferon is crucial in the initial steps of psoriasis pathogenesis, can drive activation of dendritic cells and Th17 cells. These dendritic cells also produce TNF, which block then the ability of plasmacytoid dendritic cells to produce type 1 interferons. And on the other hand, they further enhance maturation of conventional dendritic cells to produce IL-23. So if we block TNF-alpha by an anti-TNF, this negative feedback loop is blocked, and these PDCs, these plasmacytoid dendritic cells, they produce constant, not inhibited type 1 interferons, which drives a paradoxical reaction. So here, I'll show you again these numbers. So here, also Th17 dominate this anti-TNF paradoxic psoriasis, but type 1 interferons. What is very interesting, and we are working hard on that at the moment, what we found, and this is a collaboration with Lone Skov from Denmark, we found that resistant psoriasis, they have a similar profile with very, very high dominant type 1 interferons. This type 1 interferon production is even higher than Th17, so we have now the concept that this type 1 interferon is covering this Th17 pathway and is driving resistance to IL-23 and IL-17. I hope in the next future I will be able to tell you more. We have some evidence for the mechanism, but some work has still to be done. So, in conclusion, I think we have a immune balance. I've shown you these three pathways. So we have the Th17 pathway, Th2 pathway, the Th1 pathway, which are all interrelated, and they can be displaced by our biologics. So anti-IL-4 receptor dupilumab can go into Th1 or Th17. The anti-IL-17 can go into Th2, and the anti-TNF can promote an interferon, type 1 interferon-dominated inflammation. What is the consequence of that? We have resistant eczema, Th1-dominated. We have this paradoxic psoriasis, paradoxic eczema, which have somehow a flip-flop phenomena. They can go in one direction or back. And then we have the paradoxic psoriasis, which induced with anti-TNF, which is type 1 interferon-dominated. And finally, I think this will become very important, is resistant psoriasis, which are also type 1 interferon-dominated, and where the mechanism we still have to find, to describe it. I mentioned the frequency of those events, so around 5%, 2 to 6%, 5.8%. What is the underlying causing? We don't know. Is it genetics? I think it's genetics. We may have some epigenetics, some microbiome, but it will need to be determined. So how would we treat these immune shifts or paradoxic shifts? I showed you already for this resistant eczema, we chose JAK1 inhibitor because it targets interferon gamma, but I think we also should at the same time target the underlying disease. I mean, the risk if you target interferon gamma is that it switches back to the only. So far, we don't have any way to target interferon gamma signaling only, but we need to target multiple cytokine pathways. So the Th2 pathway plus the Th1 pathway, the JAK1 inhibitor. I think this is very important also in the paradoxic psoriasis eczema. Sometimes these patients do not require to go off their underlying biologics, and we just can treat it topically. But in more severe cases, I think it would be important to target both pathways, so Th17 through a JAK1/2 inhibitor, which targets IL-23 signaling and IL-4/13 signaling. Otherwise, you risk the flip-flop phenomenon. So if in a paradoxic eczema you give them dupilumab, the risk is that the underlying psoriasis will come back up. Same thing here for paradoxic psoriasis. For sure, in the context of a psoriasis, it would be optimal to target both the interferon signaling pathway, but also the Th17 pathway. And so these JAK inhibitor, TYK2 inhibitors would be the future for targeting these immune shifts. But a last example I wanted to show you is that we have also JAK inhibitor-induced paradoxic psoriasis, and we described that a couple of years ago with this patient who was treated with baricitinib for rheumatoid arthritis, developed these psoriasiform lesions on the scalp, and also these somehow pustular lesions, hyperkeratotic pustular, not very clear here. So we performed also nanoscreen analysis, and what we found is that it has a dominant Th17 pathway, but it has also very strong neutrophilic macrophages or myeloid signature. And why is that? We think that the JAK inhibitors, they're very efficient to target and inhibit multiple pathways. All these I've shown you, Th1, Th2, Th17, type 1 interferons, but they have no ability to interfere with neutrophilic pathways. And so here is again the scores for the pathways. We have a Th17 dominated, but also very strong neutrophilic dominated and macrophagic pathways. I'm showing here GPP. It looks very much like what we see in GPP. GPP also has Th17, but strong neutrophilic and macrophagic pathways, as you can imagine. The difference is in this paradoxic reaction, we don't have any type 1 interferons which are present in GPP. So with that, I come to the conclusion slide. I think I've shown you that there is a balance between immune pathways immune switches can represent the cause of non-responses. Genetics, that's my opinion, are likely to determine the predisposition to switch, but this needs to be proven. Molecular profiling may guide diagnosis and the treatment choice. JAK inhibitors targeting multiple cytokine pathways may represent a good therapeutic options for these switches. And with that, I come to the conclusion. Thank the people involved here, from my lab to the collaborators and my department in Lausanne, Switzerland. Thank you.
Thanks a lot, Michel. Any questions, please come to the microphone.
1346. Hervé Bachelet from Paris. Very nice talk, Michel, as always. Can you comment more on your last slide regarding the sort of splitting between the neutrophilic dependent inflammation, which is not touched by the JAK1, JAK2 inhibition, because in transcriptomic analysis of GPP, but also palmoplantar pustulosis, you have some patients in microarray studies or others, molecular profiling, with strong MX1 or other interferon-stimulated gene upregulation, and others they don't. And you have the CARD14 dependent, the gain of function inflammation, sometimes leading to pustular psoriasis. So my question for you is, are there different ways to go to plaque, but also neutrophilic dependent pustular-like inflammation, more than this very kind of, maybe simplifying separation between these two families? It's not a critic, of course. It's just to add something to the debate.
Yeah, of course, this was an oversimplified, and I definitely think there may be other drivers of the molecular phenotype which we observe in GPP and others. What, however, is very unique, I think, in all these paradoxical, what we call psoriasiform lesions, is they have a common Th17 seems always to be there to some extent. I mean, it's certain, it's somehow decreased, but the Th17 always comes up like as a basis. I was surprised to find that, but as really a basis of this, of probably a unique disease, which is psoriasis. And then the pathways which drive, or the mechanisms which drive these other additional pathways, they might be very distinct. I don't know if this is, I mean, you're also the expert, if that is what
No,
what
do you think? Absolutely.
You think GPP is completely different? We always see this basic Th17 pathway, which might link it to psoriasis.
Thank you.
Thank you. Chris Griffiths, final question, please.
Hi, Chris.
Thanks, Michel. You and I have talked about this quite a bit before, and I guess you're a great advocate of next-generation healthcare, which is prediction rather than being reactive. How can we predict which patients are going to get these paradoxical reactions in the first place?
That's exactly what I wish I could tell you. We don't know, and that's why I'm saying I think it's genetics, but it's my hypothesis. I know that from transcriptomics I cannot predict. So we have these pre-lesions, and we try to predict whether they would switch Th1 or they would. We cannot predict. So we need to be more granular than these transcriptomic analysis, and I think we need to integrate genetics, we integrate microbiome maybe, we need to integrate a lot of these other omics technologies in order to go down to the essence, see what it is.
Thanks.
Thanks.